everyone, and welcome to the webinar. Today's webinar will be held by Revenue Cycle, covering the 2019 reimbursement and coding updates for radiation oncology presented by Revenue Cycle. We'll be taking questions at the end of the webinar. Please enter your questions into the chat box at any time, and we'll read them out once we're done with the presentation. Just as a reminder, this webinar will be recorded and posted online. Okay, so with that, I'm going to go ahead and turn this over to our speaker. Welcome, Terry. We're happy to have you.
All right. Well, thank you. And welcome, everybody. We're going to get started and just kind of roll right into everything. I've got quite a bit of information I want to cover for today. I think overall, for oncology in of itself, not a lot of the significant changes that we've seen over the last couple of years with the coding changes, especially from the AMA and the differences in those. But there's some things I think that are very important going forward. So I want to make sure we have some time and we can cover some of those components. As I said, my name is Terry Bedard. I'm the Director of Coding Policy with Revenue Cycle Incorporated. We will have the opportunity, I'll try to make sure there's time at the end to get through any of the questions we have. If by chance we don't get to those questions, you can always email info@revenuecycling.com. Just let us know that you listened to this ACRO webinar for final rules, and we can assist you. We're going to go through the information. These are essentially the final rules that we have established for next year in 2019. There's always a distinct possibility, a correction notice or some additional information. There's a couple things we're still kind of waiting on for some more information from CMS, so there could be some stuff that could still come out for next year, but just keep that in mind. I'm going to talk just about a couple of quick coding updates. There was an actual code change for next year, just a slight definition change. We'll talk a little bit about that. I'm going to briefly talk about the hospital, the HOPS final rule items, and that's really because many of you work in a hospital setting, and so you can just be aware of a couple of things that are going on there. I think a couple of things that were directly discussed about radiation oncology, and then we're going to spend the bulk of it really looking at MPFS, the Medicare Physician Fee Schedule. What are some of those final rule items, some of the reimbursement impacts, and I want to briefly highlight just a couple of things within the quality payment program for next year as well. So we're going to roll right into some of the coding updates. So the ICD-10 code changes are on a fiscal year, which means those start on October 1st of each year. So we're already within what are considered the 2019 coding updates. But I just wanted to make sure that you're aware of them if you haven't seen those or you haven't had the discussions. There were some new carcinomas that were listed within the ICD-10. It was skin carcinoma of the eyelid. And previously the eyelid was just the eyelid. And now they've differentiated between the upper eyelid and the lower eyelid. So for those of you who may have patients that are coming through with skin cancers of the eyelid itself, you now, as of October 1st, are designating between the upper and lower eyelids. There's also some new neoplasms for sebaceous cell carcinoma. And then for those of you who may be in areas where you have patients who do with the Zika virus, there's some additional coding to identify those particular patients. I'm not going to get into those particular codes at this time, but if you have any additional information or questions about that, looking for that information, you can just let us know. So the one true code change that we have for next year is related to code 77387, which is the image guidance code that is predominantly reported by hospitals to Medicare, although for some of you in the commercial payers may be requesting this as well for physicians or your freestanding facilities. And the change really is, you'll see the second listing of delivery has been removed for 2019. So it's listed in there twice. They've just removed it after radiation treatment. So that's really the only coding change within the 77,000 series of codes for any new codes, deleted codes, and definition changes for next year. The bulk and the main reason that we're here today really is to talk about the Federal Register and the final rules that were released on November 1st and 2nd of 2018. And this is where you can find information on the Federal Register. They have releases every day, Monday through Friday, where they put out different documents at different designated times of the day. And typically, our final and proposed rules tend to come out about 3:15 p.m. Central Time to the Federal Register. And Medicare did a little switch this year. They did the MPFS, the Medicare Physician Fee Schedule, did come out on November 1st at 3:15 p.m. But the hospital one came out on Friday morning at 7:45 a.m. Central Time. So that was a little switch up, a little change for us. But when we look at all the documents that are put out there, there's really two primary ones that we focus on at this point. The Hospital Outpatient Prospective Payment System, or HOPS, and then the Medicare Physician Fee Schedule, which now includes the Quality Payment Program going forward. The proposed rules come out generally around the 4th of July holiday, although again, this year in 2018, they were a little bit late when they released those. But Medicare gives everyone 60 days to comment on the rules that they propose, to give your feedback, information. It's not enough really to say, I don't agree. They want to know why. If you have suggestions, what is your data, your information to back that up? They want to see that information to help consider and evaluate if they're going to make any changes themselves. And then they also, by law, are to release the final rules on or before November 1st of each year. So as I said, Medicare, the MPFS came out November 1st. It was about just shy of 2,400 pages long, and that's because the Quality Payer Program was a huge chunk of that. And then the hospital final rules were about 1,200 pages long. So not quite light reading, but there's a lot of information to get through. And as I said, overall, from an oncology standpoint, I think not a lot that we have to be significantly worried about, but I'm going to touch upon some things and some things to be aware of over the next couple of years with reimbursement as well. So I'm going to first quickly just get into a couple of the hospital component things to just, again, make you aware. You can also review the final rule. They do publish those to the Federal Register, so you can use the link here on the screen for that information. So a couple of things with hospitals. There is an increase next year for about 1.35% overall to the fee schedule. And what's different with hospitals, a lot of it's based upon cost. And so a hospital, when we think about it, the HOP really pertains to hospitals, ambulatory surgical centers. We're talking about the accepted off-campus provider-based departments. Those fall under the payment rates for hospitals, for HOPs. And if you're not following the quality payment reporting, there is a 2% reduction that does apply. So we do see an overall increase next year for hospitals under the facility settings, but there are some changes to some of the payments of the codes themselves, which are going to have a positive and negative impact for next year. When we look at just some of the standard courses that we have in radiation oncology, this is kind of give you just an eyeball understanding of what's going on reimbursement-wise from 2018 to 2019. And overall, any decreases that we have are not significant. They're really quite minor, less than 1%. So that's not a huge change. We see some other ones that have increased slightly for next year. And that's just where the classifications for codes in a hospital, they group codes together. So some of the CPT codes will be reimbursed the exact same amount, like your 3D plan and the IMRT plan in a hospital are paid the exact same amount to the hospital under Medicare. So when one of those changes, they're both going to be impacted. So we'll see some differences for some of those classifications in a hospital setting, but overall, not drastic changes for next year. A couple of things that I wanted to comment on and make sure that there were some specific comments about radiation oncology has to do with the comprehensive APCs. And this is something that Medicare started in 2015, and it's really part of their whole project of making sure that services that are performed in multiple different settings are reimbursed relatively the same amount. That's something that Medicare is really focused on with the quality versus quantity of care, and they're really focusing on what they consider to be site neutral as well. And so they started a lot of this packaging in 2015. We have now currently the stereotactic radiosurgery, or SRS, whether it's cobalt or LINAC based in a hospital, and then several of our brachytherapy procedures when you insert an applicator in an OR setting. What they've done in that type of setting is they take one code. For SRS, it's the treatment delivery. For brachytherapy procedures, it's the insertion of the applicator in the OR. And so that's the code we're going to pay. And then some of these other codes related to it, we're not going to pay for those separately. They're packaged into the reimbursement amount we've set for that primary code. So overall, for next year, they did add a couple of new comprehensive payment APCs, but not to oncology themselves. And they're really continuing on with what we've been experiencing. But there were a few comments within the final rule, and there was one specifically that kind of summarized comments about the radiation oncology comprehensive APCs, basically a request to do away with them for brachytherapy and SRS, and also to add code 77301, which is our IMRT planning code, into this section of code that's billed separately with SRS. So stereotactic radiosurgery is a little different in all the other comprehensive APCs, and it really comes down to, from a law standpoint, LINAC-based and cobalt-based stereotactic radiosurgery have to be paid the same amount in the hospital. One tends to be frameless. One has always been traditionally head frame, although now there's a frameless opportunity. And so to kind of level the playing field and make it a little bit easier in some ways, they pulled out some codes that they would pay separately in addition to the SRS treatment. and it includes the 3D treatment plan, but not the IMRT treatment plan. So there was a request, because there's a lot more IMRT planning going on with stereotactic, to start including that code to be paid separately in addition to the treatment delivery code itself. And Medicare basically said no. They believe that the comprehensive APCs that they have in place for these same-day surgical events meet what they're trying to do with the packaging and you know, their risk to their beneficiaries with the cost and what's going on. They feel that it meets these policies that they've been adapting. And they also are only going to pay for the 10 codes you see within the screen here. These are MRI codes. We've got CT codes, our simulation, 3D plan, and our continued physics codes are 10 codes that are paid individually in a hospital in addition to the SRS treatment codes. Now, for physicians working in a hospital, you will continue to bill your codes as appropriate, and you're paid individually for those. And they are not going to separately pay for IMRT in a hospital setting with SRS. We also had a new radiopharmaceutical that was FDA approved at the end of January this year, 2018. In July, it had a new code that was utilized. It was C9031, the LU 177. It's being changed for next year. So I know there's been some users, some people out there who are already utilizing this radiopharmaceutical for patients. So just be aware there is a code change, and it's changing from a C code to an A code. So this means traditionally, and right now since July, it's really only reported in a hospital setting with Medicare because the C code is only recognized in hospitals. It is transitioning to an A, so this means for those of you working in an office, freestanding facility, if you're utilizing this code for these particular patients, these neuroendocrine tumors, that you could also utilize and report this code. It is continuing with pass-through status. That means for the next at least 2 years, it's going to be in a reimbursement of ASP, which is the average sales price, plus 6%, until it comes off that and kind of goes into the general population. So this is a new code changing for next year for some new technology. One of the other things that happens is there's the opportunity for new drugs, biologicals, devices to also be granted pass-through when they're by different vendors. And one of those was Augmenix, who creates the Space OAR system. And they'd actually applied for pass-through status for their device of the gel itself. And there's criterion that has to be met in order to do this. And 55874 is the placement code that we use now in the hospital and the freestanding facility. And Medicare felt that for the gel that's utilized, there is no other category that it could be lumped into. So there is, that kind of stands alone that way. And the cost of the device is not insignificant. And the reason that this is important and what they're looking for with the gel really is that because when we look at that placement code, the 55874, it includes the gel itself. If it were to have the pass-through status as a separate device, it'd have the opportunity to bill for the gel separately and not be tied simply and only to the prostate placement for this code, for this device. But there wasn't, Medicare did look at some of the literature that was provided and did not feel that there was really a true justification or substantial improvement of the diagnosis with the use of the gel for those who had it and those who did not. And when they looked at treatment plans that were independently reviewed of those who had the patients with the gel and those without, they really felt that it was actually more precise planning protocols were actually needed, and the importance of adhering to those guidance protocols was really what those plans showed, as opposed to that the gel itself improved any diagnosis or treatment. So at this time, there is no, the application has been denied, which means we continue to bill for the Space OAR gel with those prostate patients only with the 55874, and we don't bill for the gel itself. Like I said, it is bundled into the actual placement code for physicians in the office setting, and then also hospitals, it's packaged, they can report it, but just there's no separate reimbursement under Medicare for that. One of the other things and components to always keep in mind, and this is again where Medicare is really changing, again, where services are performed and making sure that there's no penalty to beneficiaries because they had one service in a hospital versus an office versus an ASC, because the reimbursement can be dramatically different. So the established, what we had prior to November 2nd of 2015 was that anyone within 35 miles of the main buildings of the hospital would bill as a hospital outpatient department and were paid as a hospital outpatient department. And that changed on November 2nd of 2015, when a law was signed into and changed it from 35 miles to 250 yards from the main buildings of the hospital. And there's now a designation between accepted and non-accepted. So the accepted or those of you who've been grandfathered in, you were providing those services prior to November 2nd of 2015, you continue to bill for services as you have been. The non-accepted are those who were not granted the status when they applied for it. They started billing for services on or after November 2nd of 2015, and they're outside those 250 yards. It's important to understand when you're billing for the services, you're paid under MPFS, but you're considered for all other rulings under HOPS. And so that's where it's important to understand those designations. The reimbursement is 40% of the HOPS rate, and we'll talk a little bit more about this coming up as well. That's not a change from this year to next year, so that's continuing on. If you're in the non-accepted status, you will continue to bill your G codes for treatments and IGRT, but they all go on a hospital claim form. So it gets a little crazy and convoluted when you're trying to figure all this out. It's just important to know when you're designated and your distance from the main buildings to determine if this is impactful to you. But one change they are making for next year, and this will impact those who are grandfathered in, those that are considered the accepted provider-based departments that are off campus. They are going to neutralize the clinic visit. The G0463 is the most widely reported code under hospital outpatient prospective payment system, hands down. And there's concern that it's maybe unnecessary, that the reporting for this code, which has really been ambiguous when they set the guidelines for it, is really left up to the clinics themselves, the hospitals, to determine and how they're defining some of it. So they're neutralizing this payment just as they did with our IGRT back in 2008 for hospitals. They continue with the comprehensive APCs that we just talked about. So what this means for next year is that the clinic visit, when it's billed with G0463, in any off-campus setting, whether you were accepted or non-accepted, you will all be paid at 40% of the hospital rate. Only those hospital departments that are considered on campus will be reimbursed at the full hospital rate for this code. So this is a little switch up for those who have been in that grandfathered status for this particular code. Otherwise, you continue to bill for your services as you have been with the modifiers that you've been using. So that's just a difference of something to be aware of for next year. That in and of itself is really it for the hospital standpoint. I know it was very quick. I just want to give some the big highlights of things to be aware of for next year. I want to make sure we spend the bulk of our time focusing on some of the physician components. You can access those through the link here as well from the Federal Register. But I want to make sure we get through to some of the E&M stuff and some of the other things that came through for next year. So 2019 is still a year in which the conversion factor has an impact. It's minimal next year, but it has an impact to what we're doing for reimbursement. It was supposed to be a 0.5% increase from this year, but that changed with the budget that was signed in February of 2018, and it's only a 0.25% increase. So next year is really the final year at this point where the conversion factor will fluctuate or change and be set by Medicare. As we start in 2020 then, the conversion factor will have a 0% increase. It'll essentially be frozen at what it is for 2019 through 2025, and that's where your quality payment reimbursements, the additional monies taken from or added to, will be to identify what you're going to get paid from Medicare. And then when we get into 2026 and beyond, this is where the alternative payment models take over from that reimbursement standpoint. So next year, we are seeing about a 4 to 5 cent increase to the conversion factor. And the conversion factor is important because it takes all these RVUs that we assign to the individual codes and multiplies them and gives us a dollar amount that we can recognize. And Medicare has to operate within this 20 plus or minus $1 million budget. And so when they project that they're going to be over that, that's when they have to apply some different factors to kind of get them back into the projected budget. And so that's why we have a budget neutrality factor that didn't take us really a 0.25% increase from 2018 to 2019. So just a very slight increase. We're going to talk about some of the RVUs because the conversion factor is just one component of this. When we actually figure out, how much do we get paid for that IMRT plan? We have to look at how much physician work goes into it. Where are you geographically located? The GPC really tells us, the cost of living of where you're located. The practice expense, there's direct and indirect. We're going to talk about some of the components and things that are impacting reimbursement coming up the next couple of years with this. And that's the labor, the equipment, the supplies, and then geographically where you're located. And then the malpractice. What is the factor assigned to radiation oncology for the risk of the services that we perform in relation to your premiums that you pay as physicians? That's all multiplied by the conversion factor, and that's what gives us the dollar amount that we understand when we're looking at 77301 and trying to figure out what we're getting paid each year. So overall, for radiation oncology for 2019, there's a combined impact of about -1%. And I know it doesn't, and Medicare has a little disclaimer that these columns for C, D, and E, when they add up, they don't necessarily represent, they all show 0, but there is a negative combined impact of -1. And that's due to some changes in the RVUs. We're going to talk a little bit about that. So first I want to mention about the malpractice RVUs. And this is something that Medicare proposed some changes a couple of years ago, and they were not finalized. And really what Medicare, they're looking for comments on how do they value and really establish the malpractice RVUs for all specialties. They had proposed a crosswalk for those specialties in those areas where they didn't have the data for the premiums that are paid in order to establish a value. They do have to make some valuation for 2020. So really it's kind of a heads up. 2019, they're not changing how they came up with the malpractice RVU values for the specialties. But in 2020, there will be some changes in how they're looking at and how they have to value it and what data they're going to use for that. So they've really been seeking comments last year and this year and how they would value and use some of the data when there's not enough data available for them to utilize. The next area of the RVUs that I want to talk about and spend a little bit of time on is the practice expense. And this really accounts for the resources that are provided by the practitioner, by the physician within the area of what's going on. And there's really two different types of practice expense. There's direct and indirect. And the direct is heavily more weighted when it comes to the values of the RVUs. And this includes the clinical labor, the medical supplies, and the equipment. And then our indirect, when we think about those, is our administrative labor, office expenses, some of the other ancillary expenses that we might have. What Medicare does, and they utilize some different ways of doing this, is they look at the codes that we represent and the services that are provided. And they look at what goes into it from a clinical labor, who's assigned to that. They look at the medical supplies that go into performing the service and the medical equipment. And when they start valuing those to determine what is the actual cost, so to speak, and the resources and the labor that goes into it, the time that goes into it, that's how they come up with the RVU values. So what Medicare had done is they had employed a third party to really look at invoices and expenditures and information when it came to some of the equipment and supplies used for many different services for the valuation of setting these RVUs. And as you may be aware, and I know there's a lot of information and things that were going on after the proposed rules came out in July, some of the equipment values from this evaluation by this third party were drastically different than what was expected, or what if you looked at the information that was available, there was a lot of disagreements, there was a lot of concern as to how they were valuing it. Because what happens when the practice expense values change, that's where it can overall change the reimbursement tied to our codes. And one of those specifically was the stereotactic linear accelerator. We're also going to look at some brachytherapy stuff as well. But I want to show you a couple of bits of information for what Medicare identified and discussed within the final rules. And then they also released within some separate files. We don't really have a crystal ball that we can always use to project what's coming down the line. But I want to show you some information to kind of, so in the back of your head in the next couple of years, you're like, okay, this maybe explains a little bit about what's going on. So this is just a portion of the table of some of these supply and equipment prices that were updated in response to comments that they received from that proposed ruling. And what you'll see here are 4 of the items related to radiation oncology. So we've got our treatment planning system, we've got our HDR afterload system, our SRS SBRT system, and our brachytherapy treatment vault. You'll see in the third column is the price that we currently have. So this is the price when they're using to set some of the RVUs and the values for codes. This is the equipment prices they're using. You'll see over in the next column what was proposed, and there's some dramatic changes, especially with the SRS. We are currently at a $4 million value, and they were proposing that it would only be valued at $931,000. And you'll see over to the final column what they finalized for next year. And what CMS identified through the responses and feedback really is that when they looked at the value for that SRS system, they did not include the pricing of the actual LINAC in this proposed pricing. It was actually just the equipment to upgrade those LINACs who were not compatible or able to deliver stereotactic to have those changes. So they revalued that. It still is a change from this year to next year, from $4 million to $2.9 million for that equipment price when it comes to the values of assigning with these RVUs. I want to kind of give you just some broadcast, what's coming up in the future, because these are some extra files that Medicare had as well, and some things that they're changing when it comes to practice expense RVUs. So these are a couple of those same other additional equipment that they didn't have within this table within the final rule. So for the next 4 years, Medicare has projected out, and they're making some changes to how they're going to value and incorporate some of the values for these equipment. But these are some of the different things that are not changing over the next 4 years. They've actually put it within their files. These are the values for 19, 20, 21, and 22 years for these particular pieces of equipment and supplies. So you can see the Gamma Knife, you can see the MLC Shaper, the computer workstation for 3D radiation treatment planning. The values are set from what they are currently to what was recommended, will be carried through for calendar years 19, 20, 21, and 22. But what Medicare is changing starting next year is that when there is a transition because of values have changed, they're going to incorporate those when they're significant. They're going to implement them over a 4-year period of phasing them in. And they do this traditionally with other services. When they look at the values and things change drastically, they don't implement it all in 1 year. They want to spread it out so the impact is not so much that it could be hurtful to physicians and facilities and freestanding facility settings. So what they're finalized for next year is that when there's a transition or a phase in to values, for 2019, 25% of the value will be for the new value and 75% will be for the old. 2020 will be a 50-50 split. 2021, it will be 75 of the new value and only 25% weighted of the old. And then by 2022, it's 100% transition to the new value of those codes. So the next slide is not meant to raise concerns or anything. It's really to kind of show you how Medicare is projecting out over the next 4 years what the values when it comes to some of these equipment pricing will be. And the red is just to simply show for those that there's a decrease from where we started to where we're ending in 2022. The others, there's an increase from where we're going. So you can see some of the computer workstations of 3D that we talked about will be decreasing from the 256 to 228, the value of that. We've also, some of our brachytherapy though is going up in value for the equipment that's utilized for that. When we see like the superficial radiation therapy system, we're looking at some decreases from the value now. So they're phasing this in and showing you over the 4-year period when they're factoring in those RVUs, what they're going to be using. The reason this is important is because when we start looking at the overall reimbursement then for 2019, 2020, 2021, and 2022, this is where we can understand if there's going to be some changes in those values. Part of it may be directly related to this, whether it's up or down for what's going on for the baselines that are going to be set going forward. So again, it's not the sky is falling type thing, but it's just to kind of give you an idea and an understanding of what's coming down the line, because Medicare's not always the greatest at giving us projected out for everything that they have valued. So similar to what we did with the hospital setting, looking at some standard courses of treatment, overall not significant, again, changes. There are some changes because the RVUs are changing with the values for some of the codes for next year. As you can see with some of the stereotactic, some of the IMRT is really, for the most part, not significant changes, but those are in relation to some of the RVU values that have changed for next year. So at most a 5%, but again, it's not the sky is falling. I just want to kind of hit that home. But there are some upswings and downswings that we're looking at for next year, depending upon what your service lines might be at this point. One of the other codes that they're looking at, and they've continued to do this for the last couple of years, is 77401. And this is the superficial radiation treatment delivery code. And this code went under some drastic changes a couple of years ago, where basically there's very few codes that you can bill in addition to 77401. And CMS has really sought feedback on this. They had proposed some G codes; those were not finalized. And they're looking to see, what are some ways they can better value and represent the work that goes into this, because we can't bill for bandage, or we can't bill for planning. We can't, like I said, there's not much that we can bill with this code. Some of the comments they got, they wanted image guidance superficial radiation therapy to have its own separate delivery code. Some felt that there should be G codes, but there should not be IGRT with superficial. Some wanted a professional work component. Overall, CMS really feels that the CPT editorial panel and the RUC are the ones that, at the end of the day, if there's any changes that need to be made to 77401, it needs to come from them from a coding standpoint. And so they feel that that's really the ideal way for any changes to be made. We'll have to stay tuned to see if anything happens in the next year or two with that. One of the other things that, this is one of the things that we're looking for and waiting for Medicare to release the information as soon as they will, is a radiation therapy payment model. So the G codes that we're using in the freestanding facility, those have been in place, since we transitioned in 2015 to the codes. Many of them were deleted. We went to these G codes, and when PAMPA came out, it was really identified that we were going to be using these G codes, but there was going to be some kind of payment model to then replace them to identify how we're going to get reimbursed for these codes going forward. And it was supposed to coordinate with the deletion of these codes, which was supposed to be this year. It was pushed back with the Budget Act that was signed in February to December 31st of 2019. So those G codes that you're billing for treatments in IGRT, you're going to continue to bill those in 2019. But CMS released, a week after the final rule, they released a notice that they are working on a mandatory Medicare payment model for cancer patients, specifically for radiation oncology, to be released. Now, they didn't give us a deadline. They didn't give us an idea of exactly when they might be releasing this. Information came out today that they're working on releasing additional alternative payment models by the end of the year. They're hoping to have those out. Whether this will be part of that whole transmission and release, we're just going to have to stay tuned. But what's the difference for this is the mandatory payment model as opposed to a voluntary payment model at this point. So we'll have to see what changes this may have in place for us going forward. All right, I want to talk about the evaluation and management codes. This was a huge portion and section of the proposed rulings. And I think I don't think if you talk to anyone that there isn't an understanding or an agreement that we need to have some kind of adjustments and changes to E&Ms. When we think about the guidelines that we're using, we have the 95 and 97. So that's 1995 and 1997 are the last guideline updates that were put out. We're in 2018 going into 2019. And in that time, we've transitioned significantly to electronic health records. We've transitioned some of our technologies and services that we provide, but our guidelines that we use are fairly outdated or really antiquated in some ways. And they become burdensome to meet these guidelines versus what we're actually doing in the setting. And so Medicare proposed a lot of changes for next year. And I think that was really kind of the starting block of, we have to jump off somewhere. Let's start here and see what can happen. And so they proposed quite a bit. They didn't finalize everything for next year. I'm going to talk about this in two sections, essentially, because there's some changes for next year to be aware of. There's a bulk of changes that they actually highlighted in the final rules for 2021. And that's really as a way to prepare yourselves as providers. It's a way for Medicare to work with the AMA a little bit more closely on guidelines, any additional codes that may be needed to added, and then also give opportunity for the commercial payers a 2-year timeline to get, if they want to buy into this as well. So it's a little bit more seamless and hopefully in some ways as we move forward. So Medicare, when they looked at the values and they looked at, the reporting of E&Ms, it makes up about 40% of the allowed charges, and 20% of those are just the outpatient E&M visits when it comes to those services. So that's quite a big chunk of what we're providing to the beneficiaries. So there's 3 main changes for next year, for 2019. I'm going to talk about each of these individually. There's a reduction in the duplication of E&M documentation, teaching physician E&M documentation changes, and then a brief communication technology-based service with a new HCPCS code. As we move forward in these 3 components, what I want to make sure clearly identify is these are Medicare changes. So this is changes for 2019. Commercial payers may or may not also adapt to and take on these changes that Medicare has. So this is where you have to start having these conversations now within your departments and understanding once we talk about these changes, are you going to implement these with just Medicare and then you're going to have different guidelines in how you document things for your commercials? Or are you going to maintain the status quo at this point until you know exactly what those commercial payers are doing in relation to Medicare? Because there could be some differences when you're submitting this documentation and making sure that you have the information available upon request. So one of the first changes for next year is the reducing of the duplication of documentation. So basically, any new or established patients, Medicare is indicating for their beneficiaries that you do not need to re-enter the chief complaint and history if it's already entered by the staff or beneficiary into the medical record. Any key history or exam of established patients only, because you have that history with them, you only have to document what's changed or what's new. You still have to conduct any medically necessary inquiries and exams for that visit, but you don't have to go through the whole rigmarole of documenting everything, review systems, exams, and all that when we're looking at that information and carrying everything forward, just what's new or changed for this particular patient at this visit. And the information in the medical record must indicate that you've reviewed any of the other information that was provided separately, so that, you know, the chief complaint, or the chief history, excuse me, the chief complaint and the history, if that's documented elsewhere, you would have to notate that in your documentation, but so you don't have to repeat that. Now, this is what Medicare has had, and one of the things I want to stress is that the CPT symposium was in November, and Medicare just before Thanksgiving did a webinar of their 3 main changes under MPFS for next year, and obviously one of the biggest components is the E&M section. And there was a lot of questions posed to the AMA and to the medical directors. And Medicare on the webinar is putting together an FAQ document that's supposed to come out before the end of the year. And it's going to answer a whole lot of questions when you look at even just reduction of this duplication of information. How are they supposed to denote this information? Is it just as before, where I've reviewed this, they didn't timestamp something? So they're putting together a really comprehensive FAQ document. They said they would let people know when they released it, but there wasn't a lot of consistency in the answer. If any of you attended that webinar, they did indicate in the Q&A session of the webinar that any of those that had signed up would get notification from Medicare. I did attend it, so I will definitely pass on the information to ACRO to make sure there's distribution of that FAQ document. So hopefully, if you've got questions about this part here and going forward, there should hopefully be some more information coming from Medicare about some of these things. Next, the teaching physician E&M changes. There's some changes from 2018 to 2019, and primarily, you know, the physician's still participating. That teaching physician, there still needs to be documentation that they participated, they were present during the procedure, that they reviewed the direction of the services that were furnished. But what's different is that documentation now doesn't have to be reiterated by the physician. It can be documented by the physician, the nurse, or the resident by notes in the medical record. So this is a little bit of a change where the physician doesn't have to reiterate everything. And one of those 3 components, those 3 people involved in this, could document that participation for the physician themselves. Probably one of the newer changes for next year is a new code, and it's a virtual check-in, and it's a brief communication technology-based service. And this is something that, because of technology changes and how we're looking and working with our physicians and our patients for different things, Medicare has introduced a G code to be utilized for next year. So the G code, this is a Medicare code. Again, commercial payers may or may not recognize this service. It's a brief check-in that has to take place between the billing practitioner and the patient. And they feel that if it's utilized correctly, it will actually prevent any unnecessary office visits, reduce the waste and any costs associated with with these patients coming in for these visits that may not be necessary. So the definition for this code, the G2012, it's a brief communication. It's for established patients only, because you have to have that history. So you have to have seen this patient within the last 3 years. So they have to fall under the established patient status. It cannot originate from an original E&M service that was provided within the previous 7 days, nor can it lead to an E&M service or procedure in the next 24 hours or the soonest available appointment. So a little vagueness there, but this is a service that if your patient has a question, do I need to come in for this visit? This is what I'm experiencing. You're going to, you reach out to your patient or what have you. There's an opportunity to capture that. Right now, it's really part of our pre and post, or if it never results in E&M, it was just a service that you essentially gave to your patients without any possibility of recoupment. So the modes of technology are audio real-time phone interaction, so it can be by phone call, in addition to asynchronous two-way audio interactions that are enhanced with video or other kinds of data transmission. So if your nurse, if any other clinical staff are talking to the patient, they cannot bill this code. It has to be the billing practitioner and the patient interaction. Now, there's a couple of things to keep in mind. You have to obtain verbal consent. And in the final rule, they weren't very clear, I didn't think, distinguish this. This was, again, part of that E&M, or the webinar that Medicare did, and there was a direct question posed to Medicare, and the question was, the consent that has to be obtained, is this to perform the service or bill for the service? And Medicare's answer was, you have to obtain consent to bill Medicare for the service. And the reason for that is, many of your patients currently don't pay for this. When you have that phone interaction, it's part of the pre and post time of any E&M, or it's just a courtesy that you do for your patients. And so the question was then further posed And this is directly how they phrase it. Do you then hang up on the patient if they do not give consent, or do you just out of the courtesy of, goodness of your heart, continue the call, or however you're interacting with your patient? And Medicare really said it's up to the physician. That becomes your call. And the reason they want to make sure is they feel that there's an opportunity this could be overutilized, inappropriately utilized. Patients are accustomed to being paid or charged for this. It's about a $13 charge right now for 2019. And so they want to make sure that you have to document within the medical record, if this took place, that you did obtain verbal consent to bill the patient for this service. There are no other documentation guidelines. It just has to be medically necessary and reasonable. And you'd have to, denote that you had this conversation with the patient, but there's nothing structured around it as to what that documentation has to entail. So this is something to keep in mind. That starts on January 1st for Medicare. Again, as a G code, it's likely that the commercials will not recognize this code at this time. So let's talk a little bit about the guidelines for 2021. And this is where a lot of the changes that they were proposing for 2019, they've really pushed things back. And as I said previously, this is really to give an opportunity for providers to prepare. There's an opportunity to work with the AMA, who the AMA at the symposium recently said that, yes, they're engaged already. They've actually put together a task force. They've been quickly working on implementing and getting coding changes and how they can work with CMS on some of this for 2021. So I'm going to talk about a couple of the changes primarily for 2021. You will still be able to select one of 3 frameworks to document your outpatient, new, and established patient visits. We're going to talk about those. There's going to be an add-on code for specialized complexity, and there's a lot more information in the final rule to explain this a little better. And then an add-on code for prolonged services. So the first option framework change for 2021 really comes down to you as providers as to what framework options you want to use for your documentation. So in 2019, next year, you still continue with your 95, 97 guidelines, whichever one you've been utilizing. And then other than a few changes that I talked about previously. So that's where you're still at. When we get into 2021, this is where you have the option of selecting, do we use the 95, 97 guidelines? Do I use the medical decision-making guidelines? Or do I use the time-based guidelines from the framework that's available? What they proposed originally was to really only have 2 levels. They proposed only level 1, and then levels 2 through 5 were split in how they were valued and reimbursed. They changed that in the final ruling. So level 1, whether it's a new or established patient, you will follow the guidelines that are in there already for level 1, whether you select 95, 97, medical decision-making, or time-based. For those that fall within the level 2 through 4, again, you select your framework that you want to utilize, but you at a minimum have to meet the level 2 documentation at a minimum. So you can select whatever your code, from your documentation is, but at a minimum you have to make sure the level 2 is met. And then level 5, they pulled out because they felt that for some of those very complex patients, they want to make sure they represented that separately from everything else that was going on. So again, the same guidelines that are right now established for level 5 would be what you're going to utilize going forward for those. So that's where, again, this is starting to have those conversations at this point and thinking, what are your comfort levels? Looking at the guidelines that are in there for 95, 97, straightforward medical decision-making and time. There's a lot of requests for clarifying some more of the medical decision-making, maybe expanding some of that, giving a little bit more information on some of those. So we may see some changes in the next 2 years, but this is to start that process of what your documentation, the way that you want to proceed. Medicare has already set out what they're looking at, the values for these codes will be in 2021 when it comes to the different components within the RVUs. So they've already split these out. This is what the finalized inputs will be for 2021. And you'll see that grouping of 2 through 4 are the same, whether it's new or established, and how the level 1s and level 5s are different. So they didn't change some of how they're grouping stuff together. So this kind of gives you a breakdown of what we're looking at from 2018 to 2021. So over here in the third column, you see the visit code, the individual reimbursement rates for the individual levels of 2 through 5 for new and established. And then you can see how through 2 through 4 will be reimbursed the same amount, level 5 separate, the same thing with 2 through 4 established. And there's the opportunity for some additional reimbursement monies added onto these codes for some of the add-on codes that we're going to discuss here briefly in just on the next couple of slides. So this kind of is already giving you the values of what they're looking at for 2021 for the E&M visits. So we have a couple of add-on codes for 2021, and one is specialized complexity and one is prolonged services. There is also a complexity code for primary care. That really, they kind of outlined it. It's really for pediatrics, for geriatrics, and internal medicine. So I didn't focus on it here because I didn't feel that the opportunity may be there for some of you, but I think the specialized complexity one is one that we want to focus on. And there was a lot of confusion with regard to this code and how it was defined and how it was explained in the proposed ruling. When you look at the definition of code GCG0X, which is the temporary placement code at this point, we'll have a final code in 2021. It lists all of these different specialties. And a lot of people understood that this meant, well, only these specialties could bill this code. And Medicare's like, no, it can be billed by anyone. What the factor is in distinguishing the billing of the specialized code is that you provided parts of service, you provided services in addition to your E&M about any of these specialties, which includes hematology, oncology. So they gave an example in the final rule to clarify this a little bit better. So oncologists sees their patient, they discuss the cancer diagnosis and the treatment plan, including surgical and chemotherapy options. The physician reports the specialty add-on code, and the physician specially reported is on that claim form as well. So that, because they're going to document that within their record, that they provided these services in addition to their E&M, they could bill for this GCG0X. Now, they feel the physicians within these specialties primarily will be billing for these services pretty much hands down every time. But there's other physicians in other specialties that may be able to bill for it as well because they've included that as part of their E&M services. The other one is the prolonged services code. This is a GPRO1. And this is really because when the feedback they got is it's difficult, in addition to your E&M time, to now meet the prolonged services time of usually an hour additional time is provided. And so they came up with this G code to kind of, for levels 2 through 4 only. So these are the patients that you're only going to bill those 2 through 4. It wouldn't apply to level 1 or level 5. And you have to meet the time guidelines for those levels 2 through 4, and then an additional 30 minutes to meet this prolonged services. And you would add on this code to your E&M service in addition. So it kind of laid out a table to kind of show you how this is represented within the final rule. So the level 1 is not applicable, so we can't bill it with our level 1 code. But if you're billing a level 2 through 4 on established patient, the minute spent would be 34 to 69. And so you're going to bill your code. When it comes to the E&Ms, remember, you're going to be reporting the code that you feel your documentation represents. From a reimbursement standpoint, you may not get a separate individual rate. It doesn't matter if it's through 2 through 4. You're going to get just that one flat rate. So you're going to bill the code you feel is represented, and then you could add on that G code, the GPRO1, in addition to that code, and then that's what your reimbursement will reflect, both of those services together. If it's a new patient, you have to meet at least 38 to 89 minutes, and again, you would report your new code with then the extended services code. For the level 5 patients, it would have to be 70 minutes or more that are spent for established and 90 or more for new, and you don't get to bill that add-on G code. It's going to be the already established codes. They use the 99354 and 355 as the codes that you would add for these particular services. So that's where you'll to kind of explain a little bit more with that add-on. There were a couple of items within the proposed rules that they did not finalize for 2019 or 2021 at this point. One of them was to eliminate the provision that didn't allow for more than one visit by the same physician or specialty group. They proposed doing away with that and maybe allowing a physician to see a patient more than once for E&M on the same day of service or within the same group. They did not move forward with that. They had also proposed a reduction when an E&M is billed with the 25 modifier with another service, that they would pay 50% of the lesser value, which for many services may be the E&M. They did not move forward with that. So there's nothing in 2019 or 2021 at this point. It's possible some difference could be proposed in 2020, et cetera, but at this time, those items were not finalized going forward. The patient relationship categories, this is something that we were looking forward to seeing some more information from Medicare. We haven't had a whole lot. These are some modifiers that I'll show you on the next screen that are required by MACRA when it came out in 2015. And it's really, at this point in 2018, it's a voluntary period. And they haven't really given us when it's going to be mandatory. And we were looking for that in the final rule, but there was really nothing, there was very little about the patient relationship categories. And they were looking at maybe using these modifiers as a way of payment adjustment, but that was not finalized. So really what this is, as a provider, you identify your interaction with that patient, whether it's an episodic or continuous type service. You append a modifier to that every service that you provide to identify the type of interaction with this patient. So there's 5 relationship categories, X1, 2, 3, 4, and 5. And when we look at the descriptors of these, probably X2 would most likely apply to some of our medical oncology services. X4 does have radiation within the description of this. It is an episodic focused service, which we think about some of our interactions with our patients. They're fairly episodic and very focused on what we're doing. So this would be the X4 modifier that would be applied. So currently in 2018, it's voluntary. It sounds like for 2019, it's going to be voluntary again. There was not any other additional information. Medicare is supposed to be providing webinars and additional education on these, and I haven't seen anything yet. So I just wanted to kind of touch on those, that they still exist. They're still part of reporting on your claim at this point. We talked a little bit already in depth about the non-accepted off-campus provider-based departments. So this is one of those where they were established on or after November 2nd of 2015. They're outside the 250 yards from the main building to the hospital. From a reimbursement standpoint, they're under MPFS. From a guidelines of supervision, everything else under HOP. So we kind of straddle both of these payment systems when we're looking at how we're discussing them. Overall, for next year, it's not changing for how you're going to report your services or the relativity adjuster. I mentioned this previously. For those of you who are under that non-accepted status, you'll be paid at 40% of the hospital rate, just as you are right now in 2018. The only difference is obviously that the values in 2019 are changing, so there could be some fluctuation up or down of what that 40% looks like from the hospital rates. So they continued on with that. Like I said previously, those G codes, the G6003 and 6 through 6016, you're going to report on a hospital claim form in these settings. And then your IGRT, you report the IGRT codes as well. You're paid for these codes, not the 40% reduction. You're paid at the actual non-facility, what an office setting gets paid for these particular codes. These are continuing on through the end of next year, through December 31st of 2019. And then we look at 2020 being the year where the payment model will kick in. And that's how we'll identify the reimbursement for these particular services moving forward. We don't know what that looks like exactly. At this point, we know that that payment model is coming. We're just waiting with Medicare to release that information. The appropriate use criteria program. This is important as ordering providers for your beneficiaries. When you're ordering an advanced diagnostic imaging of CT, MR, or nuclear medicine PET, this is something that your role in this program is vital to the radiologist or the rendering physician and the facility to get paid. It starts January 1st of 2020, so this is something that they pushed it back to 2020. There's a lot of information because there's a lot of work that's going to go into this and getting things established. Essentially, you as the ordering physician would have to log into a clinical decision support mechanism tool, some kind of web-based portal, whether through an EHR or through some other portal, and input the information, the clinical information about your patient. It will help you to identify and spit out, here is the advanced diagnostic imaging that would be appropriate for this particular patient. Here's a G code and or modifiers that you will then send into to that rendering physician or and facility, and then they will then use that information, report your NPI along with that information onto the claim form, and if they don't have that information, they don't get paid. Yes, I apologize, there's a 2010, it should be 2020 is when this actually starts. And so that's where your key role comes in, because you need to supply that information to whoever's providing the service. There is one change that is happening for those as to who can perform this consultation. They proposed some differences, but what they finalized, so it's either the ordering physician themselves or clinical staff under the direction of the ordering professional may perform this consultation. And so you would delegate to that staff, but you're ultimately responsible because it's your NPI that will be on that claim form. And so they will track for any outliers for inappropriate ordering, et cetera. Right now, there is a voluntary period that started July 1st of 2018. It's the modifier QQ, and this is what you report on your claim forms to identify that you use this clinical support mechanism to look through this to determine the advanced diagnostic imaging, and you can report that on the claim form from a tracking standpoint. What's important is that cancer of the lung is one of those, provisions. So if you look here, cancer of the lung with primary metastatic suspected or diagnosed is one of the outliers already. So if you're ordering advanced diagnostic imaging for a patient who has cancer of the lung, whether suspected, diagnosed, primary metastatic, you will starting January 1st of 2020, you will have to use the support mechanism to get the information in order to supply that to the rendering facility and physician. Okay, we've got a couple minutes left. I'm going to quickly run through a couple highlights of the Quality Payment Program and see if any questions have come through that we need to address before we finish up. So one of the things, and I think this was over the last couple of meetings and things that I've attended and discussions about the Quality Payment Program, the first year, 2017, was a provisional year. And we're coming up on 2019 is the payment year for that. So you have a performance year, and then 2 years later is the actual payment year. And it's a budget neutral system, which means it depends upon how well or really how poorly some of the eligible clinicians did as to how well some of you will get paid. Because Medicare doesn't input the monies into this program. They take whatever monies are going to be paid as a positive adjustment from those who didn't meet the criteria as a negative adjustment. So what happened, I know in 2017, there's been a lot of discussions about what physicians are looking at for their reimbursement, their additional monies, not as what they expected, fairly low. And that's mainly because, from my understanding from what Medicare has talked about with this program, pretty much everybody who participated in 2017 met the criteria. Not a whole lot didn't. It was 3 points was your threshold. So they didn't have money to pull, essentially, to take back from those who didn't meet the criteria to give to those who did. So this is where it will always be hinging and dependent upon how well or how not so well any of the eligible clinicians do as to what those bonuses may look like or those additional monies may look like. What they did add on for next year's performance year, which 2021 will be the payment year, is they've added on a couple of additional eligible clinicians to the list. So they have some opportunities. There's some categories that they can participate in. There's measures that they can report. So they've added these to the already established list of eligible clinicians. They've also adjusted the low volume threshold, and they've added an additional one. So here's what the low volume threshold is: those who have allowed charges for covered professional services less than or equal to $90,000, those who provide covered professional services to 200 or fewer Part B individuals, or those who provide 200 or fewer covered professional services to Part B enrolled individuals. This is the low volume threshold. If you don't meet that at all, you cannot participate. But Medicare is actually creating an opt-in, where if you meet one of those criteria, you have the opportunity to opt in. So this is a table that they had that was pretty good explaining this. The first row here, you don't meet any of those criteria, you can't opt in at all. You're going to get the baseline rate for when it comes to the reimbursement. The other three options, at least you met one of them. You have the opportunity to opt in, to voluntarily report, or you don't have to participate at all. If you meet and exceed all three, then you have to participate. You have no option to not participate. If you're part of a virtual group, now by being part of that virtual group, you are automatically opted in. If you opt in on your own and then you decide at some point, nope, I don't want to do this, you cannot change your mind. You're locked in for that performance year. So you have to report. When it comes to the actual performance period, quality and cost, full calendar year, improvement activities, and promoting operability, a minimum of continuous 90 days within the calendar year. The weighting not changed a whole lot, although quality went from 50 to 45% of your score. They did remove one of the radiation oncology measures, the radiation dose limits to normal tissues. It was topped out, and they really feel it's a standard of care anyway, so it shouldn't be a category any longer. Cost performance will be weighted at 15% of your score going forward. For those of you facility-based, you still have to meet the 75% or more of your services under place of service 21, 22, or 23, which is inpatient, outpatient, on campus, or emergency department. If your hospital doesn't have that value-based score to attribute, then you're not eligible for that facility-based measurement. So there's some things to consider if you're facility-based. When it comes to improvement activities, it's weighted at 15% of the score. They've added some new categories, adjusted some, and deleted one. The promoting interoperability, it used to be called advancing care information. That's what we know it as of right now. It's changing. Next year, the name. You have to use a 2015 certified EHR. Starting next year, you can no longer use 2014 certified. And they're also working on this initiative to assist patients in making sure they can have access to their medical records and secure data as well. When it comes to the payment threshold, it's 30 points is what's been finalized for next year, 75 for those for the exceptional performance threshold. The adjustments is 7% plus or minus. So if you don't meet the 30-point threshold and you've opted in and you're eligible, it's up to, the maximum is 7% adjustment. For those who met it, now you have up to a 7% addition onto your reimbursement. So again, it has to remain budget neutral. So again, it has to come from those who didn't to pay for those who did. Complex bonus points will be added to the final score for those complex patients. And again, one of the bigger things is that any of these adjustments will apply to the covered professional services. They made some changes for that next year. So it's not all Part B services, it's just covered professional services moving forward. Even your payment amounts for next year, which is from the 2017 performance period, will be based upon covered professional services. They've made some changes to that, so it's not all Part B services, it's not include the drugs and so forth moving forward. So keep that stuff in mind as you're looking at what your reimbursements and your stuff looks like. I know we're right down to the very end of the hour here. Like I said, there was a lot of information. I want to make sure we were able to clarify and get through some of it. If you don't have, if I'm not able to answer any questions or you think of something after the fact, please use the info at revenuecycleinc.com. Just let us know that you listened to the ACRO Final Rule webinar, and I will assist in answering your questions. But thank you, everybody. And okay, oops, we got a question. Is the IMRT planning charge allowed for SRT as opposed to SRS? Yep. So Medicare within the guidelines has, even since 2006, has always stated to use what, the available codes for the services that you provide. So they're clear that you bill for the services. So if you've done IMRT planning, whether it's SRS or it's fractionated, that you bill for the planning that's attributed to that. So if it's an IMRT planning for stereotactic procedures, you're going to bill your IMRT planning codes that go with that. And again, this is where you have to understand now, if we're billing for IMRT or 77301, we lose our simulation codes. So the initial STEM was not going to be billable. We now have that looking at some of our special physics consults when we're looking at, because that's part of the whole IMRT planning process. You can't bill for that prior to or part of the planning process. So just being aware of those differences, you have to meet the medical necessity and the criteria for IMRT and stereotactic. But yes, if you're performing IMRT, then you should be billing for IMRT for your planning and then your stereotactic corresponding codes. Will the report be printed for access as a reference? I assume you mean the handout? Yes. I'm going to make that one correction to the date. I apologize that my finger, when I touched it, it said it should be 2020 for the appropriate use criteria program. I will change that real quick, and then I will send this over to the ACRO, to the main people there, and they will make sure that those who attended, and it's available for you to download as a reference for your information. I think that's it. I hope that means that I covered things pretty well. Like I said, not earth-shattering stuff for next year, but just some things really to keep in mind on what's going on. So good luck, everybody. I hope to hear from you, throughout the next year, and we'll talk to you again soon. Thank you.
Thank you very much, Terry. Have a great day.